Imagine a world where every CEO had the telephone numbers of patient advisors on speed dial. Imagine a world where all persons with a chronic illness received free training in self-care management, led by those living with those illnesses. And then these patients came back and they provided all the training to the physicians, nurses, and other healthcare providers in truly responsive care. These examples are not imaginary. They actually exist in a number of places already.
So what does it look like when organizations deliberately try to partner with patients and ask them the question, how can you help us redesign the way in which we provide care in this organization? And organizations that have been successful at patient engagement have created a group of people who help to orient, support, and integrate the work of patients into the ongoing work of the organization at all levels. And some of the work going on in England, experience-based co-design, puts patients and staff together on improvement teams working to make a difference in the community, in hospitals, and so forth.
I am one of approximately, I think, 60 volunteer patient and family experience advisors at Kingston General Hospital. The role of patient and family experience advisors is to ensure that the patient and family voice is heard in all decisions that affect patients and families. We are partnering with our healthcare organization to help make the system better.
What our patients and family said was, why don't we push a vision where we can imagine the patient not only in the center but inside the care team, considered as an actor of care, because that's what patients and families are, actors of care. If you, Angela Coulter, a researcher in Britain, just said recently, in a year, a patient with a chronic disease and his family, plus his family, is going to spend 5 to 10 hours with their health professionals, and they're going to spend 6,000 hours in the same year taking care of themselves. Okay, and the focus of the system today is on the 5 to 10 hours, and not very much on the other side. So that's now today the circle with the patient inside and with this concept of factors of care is at the heart of the teaching of the University of Montreal Health Sciences program. Patients have been pushing on that. Patients have been involved in the redesign of the program for the first, second, and third year of training of the 13 disciplines of health sciences.
When we started thinking about improving at the Cleveland Clinic, my boss, our CEO, Dr. Toby Cosgrove, coined this model of patients first. And what he wanted to do was create a burning platform purpose for the people that come to work every day. And his point was that, you know, if you come to the Cleveland Clinic to work, it doesn't matter what you do. It doesn't matter that you're a doctor or a nurse or a maintenance person or a valet. You're there for patients, because that's what we do. We deliver care for patients. And there's all types of different terms for describing how we work with patients. You know, we've talked about educating them, engaging them, empowering them, activating them. I like the term partnership because ultimately we need people to help us be better. As a resident, I used to walk into a patient's room and I hated when patients asked a lot of questions. It's like, you know, I got 50 patients to see in 30 minutes, don't ask me any questions. But you know what? That makes us better. We should demand that patients ask us questions because it prevents us from forgetting things. We have to move from this model of paternalism to participation.
It's time for doctors to change. You know, we know where one of the big power in hospital is. I mean, we can talk about patient engagement, patient partnership as long as we want. If doctors don't engage also, it's not going to be worth it. 5 years ago now, the Dean of the Faculty of Medicine of Montreal University, Dr. Jean Rouleau, invited me to start this initiative. And I remember very well how it happens. I mean, I was in his office, and he had the first version of the SPORE document, you know, Strategy for Patient-Oriented Research of the CIHR. He had the first version of the document, and he threw it on his desk and told me, you know, Vincent, The CIHR just produced the first version of a strategy for patient-oriented research, and no patient were involved to define this strategy. And I remember very well, and he looked at me and said, we need to have patients inside the Faculty of Medicine in order to change that. And so you're going to have a unit, you're going to be funded, you're going to be legitimized, you're going to be on our governance, and so on. So it started in September 2010.
As much as healthcare has changed in the last 40 years, some of the residual issues about hierarchy and relationships and professional pride that goes beyond the necessity of daily practice into interfering with our ability to reshape, to reform the delivery of care will be broken down if the conversation includes those people who receive care and who are interested in the outcomes and the experience and not the titles of the people that are providing them care. So we have to figure out a way to make the case about why this is a critical thing, not only because patients are and should be treated at the center of the system, but because their involvement, their engagement, I think, is critical to the transformation, the redesign of the system.
In 2008, the nursing department conducted a study of nurses' perceptions of patient and family-centered care, which served as a springboard for practice improvements. And with funding support from the CFHI and others, between 2010 and 15, the MUHC launched its most significant work on patient engagement, the Transforming Care at the Bedside program, with three main objectives. The first was to understand care through the eyes of patients. The second, to engage patients to partner with frontline care providers to redesign or co-design care processes using rapid cycle improvement. And third, to increase the amount of registered nurse time in direct care to better meet patient needs. A corporate priority of the MUHC, the Transforming Care at the Bedside program, or TCAB for short, is now in its fourth wave of implementation over a 4-year period, and it has been spread to 45% of our clinical areas in the 6 hospitals. So we have reached a tipping point.
The patient experience is not about making people happy. The HCAHPS survey, as it's administered and required in the United States, has 9 questions that relate to how providers communicate to patients. When we improve how nurses communicate at the bedside, medication errors go down, falls go down, pressure ulcers go down, and those are safety issues. When physicians communicate with patients more effectively, compliance with treatment goes up. When they communicate better with families, compliance goes up. When physicians communicate and coordinate care better with nurses, quality of care improves.
What do we do at Patients Canada to change the system? We listen to patients' experiences, and we take their experiences and we have an advisory panel that meets monthly, and we bring some of these stories to them for discussion, and we talk about them. We talk about what these experiences are and what things could be done to make them better. And we try to understand what some of the things, what are the lacks that patients express? What are the things that are missing? And so what we try to do from that is to develop very, very clear, very concrete things that can be changed that will improve the patient experience. And we broadcast them. They bring them to the hospital, and the patient comes in through the emergency room in an ambulance. In triage, there's no space for the wife. There's nowhere for the wife to be. So he tells his story, but the wife isn't there to help. She's there for all the visiting hours, but she can only be there for visiting hours, and visiting hours aren't all day, so she has to go home. And she brings no food, because you're not allowed to bring food into the hospital. As a result, he hates the food, so he doesn't eat for 3 weeks. He loses 25 pounds. And doesn't walk around much because he's wearing this hospital gown where his bum is sticking out. So he stays in bed. And of course, there are many stories that are like that. And you can see inside it all kinds of stuff that could be made better, right? And that's the kind of thing that we work on. One of the things that we suggest is, as a concrete change, a very concrete change in the emergency room, is that there be a third chair in the triage position. There is already a chair for the triage nurse and a chair for the patient. But most emergency rooms don't have a chair for the family member. But it's not there. And nobody has thought to put it there. And that's a concrete change. You can measure it. You can say, is there a third chair in the triage position in the emergency room? Some of our KPTs are in place in patient-centered institutions. I was told by the CEO of Kingston General Hospital that there are 3 chairs in the triage position in the emergency room at the Kingston General Hospital.
There has been a shift from why would we engage patients to how can we engage patients and how can we do this better.
The key success factor of what we did during the last 5 years was patients were inside. Patients were co-leading. If we want that to work, we have to be courageous, don't be afraid of each other, and believe that co-building is possible, that we share responsibility, that we share risk at the level of the care process, but also at the level of the functioning of the healthcare system. So it's time to work together.
Is it having any kind of impact? Yes, it is. We sit as part of a panel working with Accreditation Canada to develop a new series of standards for accreditation. And in 2016, we're going to have patient-centered accreditation. And a lot of these ideas came from patients and patient groups that met together to bring this, among them us.
Our advantage in the service sector is the people we're talking about engaging are right there. They're there through the care journey, they're there at those touch points, and in fact, you could almost envision, if I was being really provocative, that we're having conversations about the patient and the patient sitting, either nodding or shaking their head saying, why don't you just ask me?